Hello everyone, in this video we are going to give you information on anorexia nervosa. Our group includes Jamari Byers-Davis, Kendra Burton, Nathaniel Roach, and Sean Frazier. I will now discuss the clinical indicators of anorexia nervosa according to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, and the International Classification of Diseases, 10th revision, clinical modification. You may be asking what is the difference between the DSM-5 and the ICD-10-CM. Simply put, as a psychologist, the DSM-5 is what you would use to assist with a diagnosis or to confirm a diagnosis. And the ICD-10-CM is a HIPAA-approved set of codes used for the reimbursement purposes. While the rest of the world uses ICD-10, the United States uses ICD-10-CM, which was still largely influenced by the American Psychological Association, who are also the authors of the DSM-5. The DSM-5 has two sets of codes, one for the ICD-9-CM and the other for the ICD-10-CM. The reason the rest of the world has been using the ICD-10 since the 1990s, but the US didn't use it until October 1st, 2015. The APA was not sure when the ICD-10-CM would be released, so they included both codes in the DSM-5. As an example, anorexia nervosa is code 307.1 in the ICD-9-CM, which did not specify by subtype. The codes for anorexia nervosa and ICD-10-CM are F50.00 for unspecified, F50.01 for restricting type, and F50.02 for binge eating purging type. The unspecified type of anorexia nervosa meets the minimum requirements for a diagnosis, such as restriction of energy intake relative to requirements, intense fear of gaining weight or becoming fat, and a disturbance in the way in which one's body weight or shape is experienced. The restricting type of anorexia nervosa meets the three previously mentioned requirements, as well as the weight loss happens due mostly to dieting, fasting, and/or excessive exercise during the last 3 months. The binge eating, purging type of anorexia nervosa meets the same three requirements, as well as having episodes of binge eating and purging over the last 3 months. A few specifiers include in partial remission, which means at one time all criteria were met for a time, but now the low body weight has not been met for a consistent period of time, but the other two criteria are still met. And also full remission, which means at one time all criteria were met for a time, but now none of the criteria have been met for a sustained period of time. Lastly, psychologists have to specify current severity, which is found through body mass index, or BMI. Those levels of severity include mild, which is greater than or equal to 17 kilograms per meter squared, moderate, which is 16 to 16.99 kilograms per meter squared, severe, which is 15 to 15.99 kilograms per meter squared, and extreme, which is less than 15 kilograms per meter squared.
Hello everyone, my name is Jamari Byers-Davis and I am here to discuss the epidemiology and etiology of anorexia nervosa. Current information about the prevalence of anorexia nervosa. Up to 20% of people who experience anorexia nervosa will die as a result of their disorder over a sufficient period of time, and 5% of those will succumb from anorexia within 10 years. Anorexia nervosa has the highest mortality rate of any psychological disorder reviewed, including depression. Suicide attempts are very common among individuals with eating disorders, affecting between 30 and 40% of patients at least once in their lifetime. While anorexia is most common among females, 10 to 15% of individuals with anorexia are male. People of all ages develop anorexia, but the most common age for onset is adolescence. Current information regarding incidence of anorexia nervosa. A larger scale population survey continues to show a higher prevalence of eating disorders in younger age groups born between 1972 and 1985 than for older groups. Eating disorders are more prevalent in Western countries. More than 90% of cases are young females who live in a socially competitive environment. Anorexia nervosa is less common than bulimia, but they are exceptionally similar. Most individuals who are diagnosed with bulimia have a history of anorexia. Individuals who are often high-achieving individuals with a tendency towards perfectionism are at risk for anorexia. Also, individuals who possess negative self-images are at risk for anorexia. What is known about the causes of the disorder? With anorexia nervosa, an individual eats only minimal amounts of food, or they exercise vigorously to offset food intake so the body weight tends to drop dangerously. The ultimate goal of anorexia nervosa is to be thin. The overall fear of gaining weight and losing control while eating motivates those with anorexia. Individuals that experience anorexia are never satisfied with their weight loss. Staying the same weight from day to day is likely to cause intense panic, anxiety, and depression. I have attached an additional video about the biology of anorexia and other eating disorders to provide further clarification. Just overall, if you want more information, or if you have someone, or if you are a person who is experiencing these signs and symptoms and incidences to where you feel like you could be anorexic, please contact somebody or let somebody know so that we can help. With that being said, thank you for your time, and on to the next performance.
My name is Sean Frazier, and I will be discussing the developmental course of anorexia nervosa. Along with the symptoms that you see on the right-hand side of the screen, additional symptoms include distorted body image, refusal to gain weight, amenorrhea in girls, overevaluation of shape and weight, as well as social isolation. Factors that contribute to the development of anorexia include eating dysregulation, deficient self-regulation, attachment issues, social cultural ideals of health and beauty, high rates of childhood anxiety precede eating disorders. A history of childhood obsessive compulsive traits, notably perfectionism, rigidity, and rule-bound behavior, may also be associated with an increased risk for the development of an eating disorder. The risk of eating disorders is transmitted in families. It is important to offer particular help to parents with eating disorders who are themselves mothers. Attention should be paid to their mothering skills and attachment styles, and to their offspring to minimize the risk of eating disorders being transmitted. Further investigation of genetic contributions to vulnerability for eating disorders has occurred with two types of analysis: linkage studies and association studies for polymorphisms of specific genes. From a global perspective, suggests the presence of anorexia on chromosome 10p. And affected sibling pairs who ranked high for on drive for thinness and obsessionality traits suggest linkages were found on chromosomes 1, 2, and 13. Although decreased body weight is the most notable feature of anorexia, it is not the core of the disorder. Many people lose weight because of a medical condition, but people with anorexia have an intense fear of obesity and relentlessly pursue thinness. Psychodynamic literature suggests that patients with anorexia have been described as having difficulties with separation and autonomy, often manifested as enmeshed relationships with parents. Affect regulation to include the direct expression of anger and aggression, and negotiation of psychosexual development. These deficits may make women who are predisposed to anorexia more vulnerable to cultural pressures for achieving a stereotypic body image. This picture was taken from our textbook. If you recall, back in chapter 8, this is a picture of the French model named Isabelle, who prior to her death at the age of 28 posed for this picture to bring awareness to the dangers of anorexia nervosa. DSM-5 subtypes of anorexia nervosa: restricting type, individuals diet to limit calorie intake, individuals display depressive, anxious, and obsessional symptoms, perfectionistic traits, rigid cognitive styles, and lack of interest in sex are present in patients with restricting type. Binge eating, purging type rely on purging. Binge eating, purging anorexics binge on relatively small amounts of food and purge more consistently. Approximately half the individuals who meet the criteria for anorexia engage in binge eating and purging. Patients with anorexia nervosa of the binge eating/purging subtype may also be suicidal and engage in self-harming behaviors. Prognosis: the disorder may progress to death, with most common causes of death including starvation, suicide, and electrolyte imbalance. Subtyping may be useful in predicting the future course of the disorder, but rather may reflect a certain phase in the stage of anorexia, as confirmed in a recent study. The DSM-5 specifies that subtyping refers to the past 3 months. Prognosis is liable to change, with a better outcome indicated for onset between the ages of 13 and 18 years rather than a later onset.
Hello, my name is Kendra, and I am going to talk to you about the assessment of anorexia. And when we look at the assessment, we want to assess the patient that's suffering from anorexia nervosa, and we look at the BMI, which is the body mass index, and we look at where the patient falls on the scale. And we also look at how much weight the patient is losing. And in case you don't know what the BMI is, it's on dictionary they say that it's an attempt to quantify the amount of tissue mass, muscle fat, and bone an individual has. And they use this to categorize whether the person's underweight, at normal weight, overweight, or obese based on the value they are on the BMI chart, and it's different for men and women. And then they also have it different per ages. They have it for different ages for babies, for children, teenagers, things like that. So that's also you have to look at the ages for the BMI chart when you're looking to diagnose anorexia, because anorexia can affect people in adulthood, but mostly are looking at adolescents. And there's other different things that professionals need to do to assess anorexia nervosa, and this can include getting an in-depth interview with the patient, as well as a physical exam to look at the nature and the severity of the disorder. And it's also important to look at the other disorders that are comorbid with anorexia, because that can cause other types of harm to the patient. Other disorders that coexist with anorexia may also need treatment. And when you assess the patient, you want to look at the past diagnosis and treatments. And this is important because if they've been treated for anorexia before and the treatment's not been successful, or they've relapsed, like, we need to know what treatments have already been tried, what was successful and what wasn't. And it is important to know about, like, if it's a relapse or the first time that the person's been diagnosed with anorexia. And whenever you're going to treat a patient that has anorexia, you want to build a good rapport with that patient, because they are fearful of treatment, and treatment makes them nervous. So they're not going to cooperate with you unless you build that rapport. Okay, now we're going to talk about the treatment of anorexia nervosa. And as far as from what I saw in my research and in the book, there has been no effective drug treatment to help with anorexia. Like, sure, they use drugs to treat for other things that come with anorexia, such as like depression, or if there's going to be like some kind of heart or thyroid problem that's caused by anorexia. But as for anorexia itself, there's no drug treatment. And when treating a patient with anorexia nervosa, it's important to treat the psychological symptoms. People with anorexia nervosa have this mindset that there's nothing wrong with them. It's normal for them to be the way they are, and for them to think how they are. Like, they're really obsessed about their body size, and they think that they're fat even though they may be really dangerously underweight. So they think that everybody else is wrong and they're right. So for this, cognitive behavior therapy has been found to help. And it's important to treat the patient and try to correct their thought patterns about their point of view when it comes to how they see themselves, like their self-image and their weight and their food restricting. Like, they have to be taught what's normal for, like, eating and dieting and stuff. Like, they don't understand healthy dieting patterns and the healthy way to lose weight. They just think that they're fat even if they're not, so they're gonna go with maladaptive styles of trying to lose weight. So we want to treat the weight of the patient, especially if they're dangerously underweight, and so much so that they're admitted to the hospital. They have to gain weight before they can be discharged. So they have to make improvement for their weight. It's important that they're on a healthy scale on the body mass index. So, like, you want to, when you're treating them in the hospital, their goal is to gain weight. So you have to get them on board with that goal. They're not going to like it. They're not going to want to gain weight. And then there's also other conditions that need to be treated, like heart conditions or bone conditions. These cause other serious health concerns, but with purging and restricting, the body's not getting what it needs to do what it's supposed to. And that's one of the things that makes this disorder so dangerous. Some other conditions that can be caused can be like osteoporosis or bone mineral density problems, cardiovascular problems, endocrine problems, and menstrual function disorder. Can also cause renal problems, hematological problems, and neurological problems. So these things are all serious, and they have to be treated in addition to anorexia. anorexia can cause so many different problems. Treating the family is important when you're treating a patient with anorexia, because the family needs to be educated about anorexia and they need to be functioning as a healthy family. One of the theories of the causes of anorexia has to do with that the family is dysfunctional, but the patient with the anorexia nervosa is the symptom of the dysfunctional family. So one of the theories is treat the family to treat the disorder. So you want to teach the family about anorexia nervosa and teach the family to function properly. Also, it's important to teach the family about things such as sitting down for family meals and about healthy eating habits to care for their family member that's suffering with anorexia nervosa. That way they can provide the proper support for the family member. And family therapy, teaching them to communicate and fix whatever issues they may have, that is important for treatment as well. Thank you for taking time to listen to our presentation about anorexia nervosa, and our references are on the next 3 slides.